Hello, and thank you for streaming September's Code of the Month webinar. My name is Erin Frith, and I am a Risk Adjustment Coding Auditor here at Mount Carmel Health Partners, and I will be your host for today's webinar. We are excited to dive into this month's topic of neoplasms, but first I'd like to cover some logistics. As you know, Health Partners is providing a small incentive for your time and attention. In order to receive your payment, we ask that you watch this presentation in its entirety on demand within 60 days of its post date. Please fill out the webinar attestation and W-9 and return to Health Partners no later than November 23rd. We encourage you to watch the content at any time, but you will only be eligible for the incentive through November 23rd, 2020. Now let's get started. Our speaker today will be Dr. Daniel Wendorf. Dr. Wendorf is the President and Chief Medical Officer of Health Partners and a board-certified internist. He practiced as a primary care physician in Grove City for 25 years prior to joining Health Partners in 2009 and is an expert in alternative payment models, clinical integration, and population health. Welcome, Dr. Wendorf.
Thank you, Erin. It's a pleasure to be here to discuss this topic with you all today. Before we start discussing the specifics of today's webinar, let's review some risk adjustment essentials. Risk adjustment is the methodology by which CMS determines how to adequately allocate resources to Medicare Advantage plans for patient care. There are many factors that determine resource allocation, both demographic and clinical. Demographic examples include patient age, patient gender, institutional status, Medicaid status, and the reason for being Medicare eligible. Clinical factors include chronic conditions that have been shown in CMS data to require more resources. There are 70,000 diagnosis codes included in ICD-10. Every year, each code is evaluated using CMS data to determine which codes utilize the most resources. Once that is done, the data is normalized so that an average Medicare Advantage patient has a risk score of 1.0. Around 9,500 diagnostic codes are determined to affect risk, and they each map to what is called a hierarchical condition category, or HCC. An HCC is a group of chronic condition diagnoses that are clinically similar and have been determined to have a similar effect on resource utilization, what is called their weight. These weights are what calculate the clinical portion of a patient's risk score. There are 86 HCCs that are included in the 2020 risk adjustment model. For diagnosis code to be appropriately included on a claim, it must have supporting documentation within the record. An easy way to remember the documentation requirements is the acronym MEAT, M-E-A-T, which stands for Monitor, Evaluate, Assess, and Treat. Only one of these elements needs to be present for each diagnosis. Now that healthcare professionals are working to deliver the same level of care to patients during the corona pandemic, we wanted to discuss the standards for capturing HCC during telehealth visits. These telehealth visits must be completed by an approved healthcare provider, either a physician or a nurse practitioner. The visit must have both real-time audio and visual capabilities, and it is stated within the documentation that both audio and visual were used. Now let's move on to neoplasm-specific information. As you know, neoplasms are a group of diseases characterized by uncontrolled growth and spread of abnormal cells. It is estimated that 1.8 million new cases will be diagnosed in 2020, and about 606,000 cancer deaths will occur. That totals out to 1,660 deaths per day. These totals do not include skin cancer, as these cases are not reported to the registry. There are over 500 ICD-10 codes and 5 different HCCs for neoplasms, which we will go into further today. Although the cause of most cancers are still unknown, We do know that there are specific risk factors that can determine the likelihood of someone developing cancer. These risk factors include an increased likelihood as you age, with over 80% of cancer patients being 55 or older. Weight and BMI play a large role, as well as smoking and alcohol consumption. Patients who have a family history of cancer are also experiencing a higher risk of diagnosis. Testing includes routine screenings, such as blood tests, mammograms, colorectal screenings, and Pap tests. As stated before, there are 500 ICD-10 codes for cancer, which can be organized into 5 different HCCs. These categories include metastatic cancer and acute leukemia, lung and other severe cancers, lymphoma and other cancers, colorectal, bladder, and other cancers, and breast, prostate, and other cancers. It's important to be as accurate as possible in medical record documentation, as well as the diagnosis codes that are selected. By choosing the most accurate and specific code, healthcare professionals are able to fully express the patient's burden of illness. First, determine if a neoplasm is benign, in situ, malignant, or uncertain. Malignant neoplasms with metastases should have their metastatic sites coded. Once a primary malignancy has been eradicated, Z85, the personal history of malignant neoplasm, may be used as a secondary code. It is important to properly document and code whether the patient's cancer is ongoing or in remission to better represent the patient's burden of illness. Primary malignant neoplasms should be coded as active when they are actively receiving treatment or being managed. This active code should be used until there is no further treatment required for the site, or if the patient is not in remission but has opted out of treatment. Category Z85, or personal history, is to be used when the patient is no longer receiving any treatment and the neoplasm has been eradicated by said treatment. There are a few exceptions when it comes to cancer documentation. These exceptions are leukemia, multiple myeloma, and malignant plasma cell neoplasms. In general, these conditions do not use personal history codes. Instead, these conditions should be documented as active or in remission. In the example on the slide, included about multiple myeloma, there are codes available for not having achieved remission, in remission, or in relapse. Although not specifically related to HCC, we would like to now address a few clinical quality gap closure tips for neoplasms, especially since we are coming closer and closer to the end of this calendar year. In order for breast cancer screening to close a gap in 2020, there must be documentation that a mammogram screening was completed between October 1st, 2018 and December 31st, 2020. It's important to remember that in order for it to count, it must be an actual mammogram report completed by a professional. Self-reporting is not acceptable when closing this gap. Biopsies, ultrasounds, and MRIs are also not included. In order for a colorectal cancer screening gap to close, one of the following must be met: an FOBT completed in 2020, a Cologuard completed in the last 3 years, a Flex Sig completed in the last 5 years, or a colonoscopy completed in the last 10 years. We've compiled a few coding examples to demonstrate good documentation and coding principles. I'm going to turn it back over to Erin to discuss those examples.
Our first example is a 66-year-old female who is seen for a chronic condition visit. She is a current smoker with 1 pack a day for 30 years. Recently, during a routine visit to the pulmonology for her COPD, a mass was found in her right lower lobe. Biopsy was completed and found to be malignant. She is currently scheduled for a lobectomy next month. Her COPD medications were adjusted due to her worsening symptoms. For this example, we would select code J44.9, chronic obstructive pulmonary disease unspecified. The secondary would be C34.31, malignant neoplasm of the lower lobe, right bronchus or lung. Our second example is a 72-year-old male being seen for AWV. The physician reviews all pertinent health conditions with the patient. The HPI states that the patient is status post prostatectomy in 2014 for prostate cancer. Patient notes that he follows yearly with oncology for surveillance. For this example, the code that we should use is Z85.46, personal history of malignant neoplasm of prostate. In our next example, a 70-year-old male who is here for routine blood monitoring. He was diagnosed with chronic lymphocytic leukemia 4 years ago and is now in remission following chemotherapy completed 2 years ago. Lab results reviewed and levels continue to be unremarkable. In this situation, we would code C91.11, chronic lymphocytic leukemia of B cell type in remission. Our last example is Mrs. Smith, who is being seen for increased hot flashes and mood swings. She is a 67-year-old female currently on tamoxifen for the last 2 years for previously diagnosed breast cancer in the left lower inner quadrant of the breast. After examination, the physician notes she needs an adjustment of her tamoxifen and instructs her to schedule with her oncologist. For this encounter, the code C50.312, malignant neoplasm of lower inner quadrant of the left female breast, would be the correct code choice.
To conclude our time today, we have a few takeaways from our presentation. Detailed documentation and selecting the correct, most descriptive ICD-10 code are important for accurately capturing the patient's burden of illness. Document if the patient is seeing a specialist on aromatase inhibitors or currently receiving other treatments. When selecting the proper codes, keep in mind that a neoplasm is considered active if it is not in remission and the patient has opted out of treatment. Otherwise, use a personal history code for patients who have completed their treatment and their condition is eradicated. We have a few upcoming webinars. Next month's webinar will focus on substance abuse documentation and coding. November's topic is to be decided, and there will be no webinar in December. Here you'll see the references that were used for the information presented today for anyone who is interested in looking further. Please feel free to send questions to any of the people listed below, and we will be happy to answer. Please remember to return attestation documents to Ellen Johnston by November 23rd, 2020. Thank you for taking the time to watch this webinar. We hope this has made you more comfortable with documentation and coding.